Welcome to Cutting to the Case with Bhav Jain and Cameron Savitt. We are third-year medical students, and we are excited to welcome our next guest, Dr. Gail Rosseau, an internationally recognized neurosurgeon, educator, and global health leader. Dr. Rousseau is a clinical professor of neurosurgery at George Washington University and adjunct professor of global neurosurgery at Barrow Neurological Institute. She is board certified by the American Board of Neurological Surgery, and her clinical expertise includes skull base and pituitary surgery, microvascular compression syndromes, and traumatic brain injury, with a current focus on caring for veterans. She earned her medical degree and completed her neurosurgical residency at George Washington University, followed by advanced fellowships in cranial base and microvascular surgery in both Paris and Pittsburgh. Dr. Rousseau has been a trailblazer in global neurosurgery and a champion of equitable access to surgical care. She serves as vice chair of the G4 Alliance and sits on the executive board of the World Federation of Neurological Societies Foundation. She has long supported education and injury prevention through leadership roles in the Foundation for International Education in Neurosurgery and Think First. A prolific academic, Dr. Rousseau has authored over 150 peer-reviewed publications, is global champions editor for World Neurosurgery, and leads NIH-funded initiatives to build traumatic brain injury registries and surgical training programs across Africa. She's also a co-founder of the Global Alliance for the Prevention of Spina Bifida F, which partners with WHO member states to eliminate this preventable condition. Notably, she was a candidate for U.S. Surgeon General in the Obama administration, a reflection of her deep commitment to public health leadership. Beyond her technical and global contributions, she's a tireless advocate for mentorship, interfaith collaboration, and expanding opportunities for women in surgery. We're truly honored to have her with us today, and we think you will really enjoy this episode.
So, first off, again, thank you so much for being here.
You're welcome, Bhav, and I hope we haven't lost the entire audience with all of those kudos. Not necessary, but thank you very much.
No, absolutely. So, my first question is, what first inspired your interest in global neurosurgery, and how did you navigate forging that path in what is otherwise viewed as a high resource subspecialty?
Yeah. Well, that's probably a very good place to start, Bob. It begins with a story, as many of our decisions do. So when I was a little girl, we would go on driving vacations around the country. And very often we would stop in and visit friends of my parents, my dad's friends from the Marine Corps days. And in this case, I want to tell you about someone who lived in Central Ohio, who is the daughter of these people, and she was about 6 years older than me. Her name was Jenny, and I only saw her once or twice a year, but she was just that much older that a middle school and then junior high age girl would really look up to her. She just was nice to me, paid attention, and I just thought the sun rose and set on Jenny. And I didn't see her much after I was in junior high and she finished high school, but I learned through her parents that she, not surprisingly, had joined the Peace Corps, and she was sent to teach children in rural Tunisia, and I admired her even more. And so you can imagine how badly I felt when I learned that on her day off, she had been taking a group of students walking by foot to the next town. And as you would expect with someone of her good character, she was on the roadside of the road, keeping the kids out of harm's way. And you know what happened. She was hit by a car. And although she was a Peace Corps volunteer and therefore could be medevac to Landstuhl, the big, forward base in Germany of the U.S. Army, and then home, she did not survive. And it affected me a lot. I just thought it was such a waste. But life goes on, and it went to the back of my mind until the time when I was a first-year resident, and I did my first craniotomy under supervision for an epidural hematoma. And that night, I reflected on how very straightforward that operation was. I mean, it was simple enough that even I could do it safely under supervision as a first-year resident. And it hit me again like a wave that here was someone who didn't need to die even from that injury, and yet she did because of lack of access to care. And of course, anyone that she worked with would not have even had that opportunity to be medevaced out and maybe be saved. So I think that was the first seed that both directed me to surgery, but at the same time toward access to surgery.
I appreciate that. Thank you very much for sharing. It's quite fascinating. I'm actually on neurosurgery rotations right now, so I'm seeing a lot of these as well.
Yeah.
So with regard to neurosurgical need that you were discussing, what do you see as the most pressing unmet neurosurgical need globally, and how has that changed over the last decade? Or for spine surgery, I'm interested in orthopedic spine.
Yeah, great. Well, there's a great need for all of neurosurgery. As you know, the Lancet Commission report and our analysis of it shows that there are more than 5 million urgent neurosurgical operations that need to be done every year that can't be done because in part because we don't have enough neurosurgeons or neurosurgical equipment. So there's a huge need. But if you ask what is the biggest need within neurosurgery, it's not skull base, although I clearly love it, and that's been my career. It's not even spine surgery, it's trauma. So 20 million people die of TBIs every year. 20 million, think about that. That is like having 3 entire global COVID pandemics every 4 months, year after year after year. So that is our greatest need. It's not the only thing. We can't only pay attention to that, but we really need to accelerate our attention to first and foremost preventing it and use our bully pulpit to do that, but also to expand access to needed care, because there's a lot of people like Jenny who have non-fatal TBIs that become fatal because of lack of personnel and equipment.
And I'm interested to dive a bit more into this issue of how we actually support from an infrastructural standpoint the development of neurosurgical workforces in other nations. And I'm asking this specifically with the broader context of the fact that entities and agencies like USAID and who have lost a substantial really amount of funding over these last few months, as these funding shortages become more and more acute, many of these low and middle income nations are looking into ways to actually fund their own infrastructure in a more independent way. So how do you see us as the US or other high income nations being able to actually support all of that work without leaving our low and middle income nation these other nations in a situation where they are overly reliant upon us?
Yeah. Well, Bob, that is a really good question. And it's one that probably tens of millions of public health officials are grappling with now. Look, I think that the manner in which USAID was defunded and the abrupt pullout of the United States as a member of WHO was both capricious and cruel. However, it is true that no nation, no matter how wealthy or how generous and good-spirited, can support the healthcare of the rest of the world. There are many countries that were using USAID for a half or 2/3 of their national health budget. And of course, that's not sustainable. So it is my great hope that despite the fact that I would not have reduced the involvement of the United States at all in the same way as it has been done, I'm hopeful that it will be a wake-up call for new systems and new ways of thinking about this, new paradigms. And one of the best has been, this doesn't really address how one pays for healthcare, but it does address how we train up more people to deliver healthcare locally. And that has been twinning programs, partnerships between residency programs, not just in neurosurgery, but in all the disciplines, where we can clearly see the benefits that are bilateral. So this idea that all knowledge, wisdom, and resources somehow trickle down from a high-income country to low and middle-income countries has got to stop. I'll give you a great example. Within neurosurgery, we now have a much, much better way of dealing with pediatric post-infectious hydrocephalus because a neurosurgeon, namely Ben Worf, moved himself and his family to Uganda originally forever. That was his plan, in order to study the problem and find ways to treat it locally. And that's the reason why endoscopic third ventriculostomy, choroid plexus cauterization, shuntless ways of being able to deal with this very widespread problem were developed. So that's one example of the lessons and even the basic science of a condition being able to be studied anywhere, in this case, in a place of high volume, and then transmitted through careful analysis and scientific study and peer-reviewed publication to the rest of the world. Another example is spina bifida, which occurs much more often in countries that are low and middle income countries where the majority of their cereal grains are not commercially prepared. So there's no added folic acid. And so here too, we're going to be able to improve our residency programs in North America if our residents can spend some time training, not with somebody who does a dozen a year, because that's all they have in, some major city in North America, but with someone in Ethiopia who does 800 a year. So those are two examples of the benefits of the time that we're moving into, and the challenges, but the potential.
Yes, thank you very much for sharing that. We also understand, speaking of potential and looking forward, that you are one of 300 female neurosurgeons in the United States. Now,
well, there's a whole lot more now. Now that we look at the numbers every year, but I think that about 8 or 9% of the practicing neurosurgeons board certified in the United States are women now, and 17, 18, approaching 20% of the residents. So it's not so unusual anymore. But I understand your point.
Yeah, well, that's fantastic to know. Well, maybe even more pertinent to the question then, what have you found to be most effective in elevating women and underrepresented voices in global neurosurgery?
I think it's just a matter of fairness, right? It's not so much doing things to elevate people of any specific gender or race or religion or age. It's just making, a playing field that is accessible to everyone and then rewarding merit. Now, sometimes that takes a little bit of work, all of us find that we don't know what we don't know. So it's not exactly fair if someone has no knowledge, say, of neurosurgical practice in their entire community up through high school, to think that somehow it's just going to pop into their head. Well, maybe I want to go into neurosurgery. So I do think outreach programs are important.
Something else that we were interested in asking you, especially as we move into an era of AI and virtual telehealth, is how do you see these new tools and technologies really being able to improve the ways in which we engage in workforce development in other low and middle income nations? And are there any examples you've seen of such models actually being deployed or implemented at scale?
Oh, absolutely. So, we talk about these things as the future, but I'm here to tell you the future is now. And you guys aren't just the future of the field, you are the impatient present. So to give you just some examples, and this first one is from, I think, 3 years ago. I was interested in how one coaches or guides surgery at a distance. And we've been doing this with various technologies for some years. And Johns Hopkins was doing this in very rural Kenya with obstetrics. And so I went there to see what they were doing, and I met a young OBGYN, fully trained, and she was one of 3 consultant obstetricians in a 9-county area that had a district hospital in each of those counties, and it's absolutely impossible to be able to go from one to the other in a reasonable period of time for a delivery. So you have 9 really disparate hospitals, 3 people who can do an emergency C-section. So they were doing a program, and they were already into this program as a grant-driven study that they are now reporting to look at what the outcomes were when general medical officers, those are people who have been 1 or 2 years out of med school, right? So just a couple, 3 years older than both of you, who are the only person there when a young woman comes in obstructed labor and needs to have an emergency C-section. Now, you're not learning how to do this for the first time over the internet. There's training and special training so that there you graduate from med school knowing your way around a C-section. And then in this case, and I saw it with my own eyes, someone who was 14 months out from med school graduation, under video supervision, safely did a cesarean section, and both mother and baby were fine. We're going to need to do a lot more of that in a lot more disciplines. That certainly is going to be part of the answer, at least the interim answer, for traumatic brain injury. We don't have time or the brain doesn't have time for a patient with an epidural hematoma to be transported to where the neurosurgeon is, or even for the neurosurgeon to go there. We're going to need to have training of general surgeons, of GMOs, so that they know what to do in this specific case. And then we have eyes on them and can help them through the procedure at a distance.
Yes, and additionally, about helping people in procedures as well, and moving forward. Well, actually, I'd like Bhav to ask the final question, if he'd be open.
Oh, okay. Yeah. I guess just based on if you have a few more minutes, I'm happy to ask the last one. Or if you have even more minutes, then Cameron can first ask, and then I can ask her last one. Whatever works best.
My time is yours.
Okay. Maybe, yeah. Why don't you, and I'll ask afterwards.
Sure, of course. So, okay, in that case, what advice do you have for trainees who want to engage in global neurosurgery or spine surgery policy work early in their careers? And how can they get involved on the global or leadership stage?
Great. That's a very good question. I'm happy to address it. I would say there are 2 things that are really important. My first message, first and foremost, is you have to be good at your specialty. So your medical training is primary and always will be. You're no good to anyone in your country or any other country if you're just a so-so doctor of any kind, whatever your specialty is, medical or surgical. And now we're talking about these issues, looking, using a little different nomenclature. We're looking at the procedurally related specialties, rather than the division that we think of classically in the United States, surgery versus medicine. So now, for the WHO, for example, they talk about the eco specialties. Now, they're not talking about ecology, they're talking about emergency, critical, and operative care. That's the ECO. And that's because these are the specialties that are procedurally driven. Emergency physicians intubate, put in chest tubes, they're kind of part of what of surgical practice, because they do surgical gestures. And same thing with critical care, putting in, all these kind of lines, again, chest tubes, endoscopy, and so forth. And of course, all different operations and anesthesia. So surgery really is much, much more broadly defined now, and they're grouped together for a good reason. Those kind of procedures require the same kind of infrastructure in a hospital. They're costly and complex, so they're kind of grouped together. But so my first answer to your question is you just have to be good at what you do, both, sort of intellectually as well as physically, good at those things that you do. And that really should be primary. Having said that, there are a number of ways to get involved. Let's think of it as like an extracurricular activity, or being an athlete if you're also a student, right? And so there's a whole variety of things. So medical students and trainees can be members of Incision, which is a big global network of students involved in EcoCare. They are a member of the G4 Alliance. The G4 Alliance, which I chair, has a really, I think, excellent and certainly highly regarded fellowship program, where every year we take, a cohort of 16 students from around the world, not all even medical students, but people who are interested in global health. And they go on to do great things. One was recently a White House fellow. So you can apply for that. Applications for that are every April. Harvard has the program in global surgery and social change. That's an excellent fellowship. Foundation for International Education and Neurosurgery, FEANS, has a number of clinical fellowships available that are wonderful, probably more than any others in neurosurgery. The Global Surgery Foundation, based in Geneva, has policy fellowships. Operation Smile, wonderful, huge Virginia Beach-based, large NGO, has surgical advocacy fellowship. So there's, I could go on and on, but I think either taking a gap year or finding a way to be involved in a group like Incision or International Surgical Student Association is a good way to combine focusing on your primary task at hand, which is becoming whatever specialist you're going to become, as well as gaining knowledge and also building community.
Excellent. So I'll ask our last question, and I must say this has been a very, very wide ranging and exceptionally interesting conversation. So just want
Thank you.
to once again offer our thanks there. So for our last question, I would really love to hear from you, in the years ahead, what do you hope the rest of your work and your legacy in global health and in global neurosurgery will offer? And how do you hope to eventually and later on be remembered as well?
Wow. I wasn't really thinking about what to put on my tombstone when we sat down to talk. So I don't know if I can address that. But what I will say is that my real passion something I think about every day, many times a day, is what am I doing today to improve access to quality, affordable, safe care, surgical care, often but not always neurosurgical care for everyone who needs it. And so I don't think that problem will be completely solved in my lifetime. I would like it to be. I doubt that it will be. But, we're all just putting our own little brick in the wall of human history. And I hope that mine will be that, we're making a very solid foundation and bridge to a better future where people like Jenny and Jenny's students and their families don't die from that. That's the first thing. And then even more important probably is finding a way to prevent that, right? And I think I'm optimistic about technology being really important in this. So I guess that's what I would say.
Excellent. Well, this has been outstanding. So thanks again, Dr. Rowe. So we're wishing you all the best in the months and years ahead, and we really, really appreciate it.
Well, it's my pleasure. It's great to be with you, Bob, and with you, Cameron. And please keep in touch.
Absolutely.
I will follow your careers with great interest and happy to help any way I can.
Absolutely. Thanks again.
Okay, thank you.
Bye. Take care.
Okay.